Good afternoon, everyone, and welcome to our webinar entitled Addressing Cataract Surgery in the Wake of COVID-19. A special good afternoon to our featured speaker, Professor Bernie Chang, joining us from the UK, and to all who have registered and logged on. My name is Franca Mohammed, and I am the Stakeholder Engagement Manager at CBRS and Trinidad Eye Hospital, and I will chair this afternoon's meeting. Please note, we have a few house announcements before we begin. The meeting is being recorded. Please mute your microphones unless you are addressing the group. If you would like to speak, please raise your hand. When called upon, you may unmute your microphone, introduce yourself to the group, and turn on your camera if possible. Please take a moment to have a look at the agenda on the screen now. We have a really exciting program for you this evening, and we really hope you enjoy the discussion that we are about to engage in. During the course of this meeting, please feel free to utilize the chat box to post any questions or comments you may have. So to start us off, I now invite Dr. Paul Edwards, who is the advisor of Health Systems and Services at PAHO WHO, Trinidad and Tobago, Aruba, Curacao, St. Martin, Bonaire, St. Eustatius, and Saba to officially welcome us to this webinar. Dr. Edwards.
Thank you very much, Franca. A pleasant good evening to all. In the last 2.5 years, health systems around the world, across the Caribbean, and also in Trinidad and Tobago have been challenged by increasing demand for care of people with COVID-19, compounded by fear, stigma, misinformation, and limitations on movement that disrupted the delivery of healthcare for all conditions, including cataract surgery, the very core of today's webinar. When health systems are overwhelmed and people fail to access needed care, both direct mortality from a pandemic and indirect mortality from preventable and treatable conditions increase dramatically. Maintaining population trust in the capacity of the health system to safely meet essential needs and to control infection risk in health facilities was key to ensuring appropriate care-seeking behavior and adherence to public health advice. On the other hand, the health system's ability to maintain the delivery of essential health services depended on its baseline burden of the disease, the local COVID-19 transmission scenario, and the health system capacity as the pandemic evolved. We saw that in the early phases of the COVID-19 pandemic, many health systems were able to maintain routine service delivery in addition to managing a relatively limited COVID-19 caseload. As demands on the health system surged and healthcare workers themselves were increasingly affected by COVID-19 and the indirect consequences of the pandemic, strategic adaptations became urgent to ensure the private and public sector resources provided the maximum benefit for the population. Countries were challenged to make difficult decisions to balance the demands of responding directly, to the COVID-19 pandemic with the need to maintain the delivery of essential health services. However, many routine and elective services were either canceled, were delayed, or put on hold, and existing delivery approaches had to be adopted to the evolving pandemic context as the risk-benefit analysis for any given activity changed. We're all aware that the course of the COVID-19 pandemic is likely to continue to wax and wane, and the strategic response will need to be dynamic and calibrated. Successful implementation of strategic shifts will require the active engagement of the communities and public and private stakeholders, specific measures to ensure access for socially vulnerable populations, transparency and frequent communication with the public, and a high degree of coordination from individuals. The need exists for interaction reviews to be conducted and highlighting what worked and what did not work. It is very clear that investments, including human, financial, and medical products and technology in primary healthcare for universal health can provide a critical foundation for adapting to this pandemic context and others to come. I end by sharing that a well-organized and prepared health system should have the capacity to maintain equitable access to high-quality essential health services throughout an emergency or even a pandemic, limiting direct mortality and avoiding indirect mortality. Welcome once again to today's webinar, specially prepared for you. Thanks.
Thank you, Dr. Edwards. That was a very warm welcome, and we are so pleased to have this forum to shine a much needed light on this topic as it relates to blindness prevention. Now it is my pleasure to welcome Dr. Erica Wheeler, who is the PAHO WHO representative of Trinidad and Tobago, Aruba, Curacao, St. Martin, Bonaire, St. Eustatius, and Saba, to share some opening remarks. Dr. Wheeler.
Well, thank you very much, Franca, Ms. Mohammed, as I should call you, but very much a pleasure to see you, even if virtually, and to be part of this. I want to also begin my brief remarks by welcoming Professor Bernie Chang, President of the Royal College of Ophthalmologists of the UK, the persons from the Ophthalmological Societies, Dr. Ramdath and Dr. Allen, Dr. Ramdath being the President of the Ophthalmological Society of Trinidad and Tobago, and Dr. Allen, President of the Ophthalmological Society of the West Indies. Also a hearty welcome to Dr. Bola, who I am always, as ever, pleased to see, who is both the CEO as well as the eye surgeon at the Trinidad Eye Hospital. Dr. Kumar is consultant ophthalmologist, welcome. Also Dr. Dwarika, who is a consultant ophthalmologist as well with the team. There are various medical directors who are online. I haven't had the opportunity to see if each and every one of them are here, but I know certainly Dr. Abdul Richards was invited, as well as medical directors of the regional health authorities. Dr. Abdul Richards is our principal medical officer for institutions at the Ministry of Health. We also should have online heads of Department of Eye Health of the 5 regional health authorities, as well as the head of Department of Ophthalmology of Guyana, Dominica, and St. Lucia, who registered. And of course, we also invited CEOs of the 5 regional health authorities. Welcome if you're all online. Our own Dr. Edwards, as well as medical practitioners and all other specially invited guests. So good evening and welcome again. It's great to see so many of you online, and I recognize your commitment to attending this webinar out of office hours, which I dare say has become more common during the last couple of years as a result of COVID-19. So we're here today, as was introduced, to talk about cataract surgery in the wake of COVID-19 challenge and the way forward. So colleagues, as we all know, the ability to see plays a critical role in how we experience and interact with the world around us. It's probably something many people overlook and take for granted. However, to the many surgeons and practitioners participating in this webinar, you know how precious sight is to those clients that you care for and for whom you provide ongoing services, and how much it really means to them. It's a well-known fact that the ability to see well and access quality eye care services can have a profound impact on one's quality of life. And there is a short video that would be shown by the Eye Hospital coming up that would bring that home to you very clearly. We know that persons with disabilities, which includes those who are blind or who have vision impairment, face many barriers, including economic, institutional, physical, attitudinal, and even cultural, that hinder their full and equal access to their enjoyment of human rights and full social interaction. And many studies have corroborated the fact that there's a consistent relationship between vision impairment and a reduced quality of life. So it's my belief that this webinar and forum that we're about to embark on will go a long way towards both further heightening awareness and underpinning the importance of this surgical procedure that can improve or enhance the quality of life for many people before it's too late. According to the World Health Organization World Report on Vision 2019, there are approximately 2.2 billion persons suffering with a form of vision impairment, of which 1 billion are yet to be addressed. In our region here of the Americas, it's estimated that over 300 million people suffer from some form of vision impairment, and over 3 million people over the age of 50 suffer with a form of blindness. Alarmingly, it's estimated that over 80% of all these cases of blindness could have been avoided with proper access to eye care services. The COVID-19 pandemic has profoundly impacted the ability of public health systems around the world, not just here in Trinidad and Tobago, to deliver health services to their populations. And millions of surgeries, as we heard, were delayed or altogether canceled. In Trinidad and Tobago, at the height of the pandemic, government was forced to postpone all elective surgeries, including eye care services, leading to a considerable backlog in the public health system. And I know you at the Trinidad Eye Hospital have been assisting with that. So many people are at risk to suffer eye complications and blindness due to their condition not being treated or due to not being able to visit a physician to have their condition diagnosed. Furthermore, pressure placed on practitioners to address this backlog and provide their services to patients whose services have been delayed. In addition to new services, this has all developed and made their conditions worse during the pandemic. So it's really critically important to address this issue of cataract surgery, and where other countries also suffering from the negative of the pandemic, the negative impacts of the pandemic, like some of you online, hopefully I mentioned Dominica, Antigua, and so on. It's very important to address this issue. Cataracts can be surgery being simple, and one can reverse the condition, and it's also a cost-effective healthcare intervention, because vision impairment still represents one of the leading causes of blindness in Trinidad and Tobago. There's a general misconception by the public that cataracts are a condition that mostly affects the older population, but we know through recent data that increase in risk factors such as diabetes, obesity, poor nutrition, which we all know too well in the Caribbean, these also have an overall impact on the health of younger people, and cataracts are showing up much more frequently in the younger population. We estimate that about 1 in 5 people will develop a cataract by the time they reach 40. If this issue is not addressed, the volume of people needing to access cataract surgery will exceed the rate at which the health system can deliver such services. And this will lead to further delays, backlog, and economic losses for both the state as well as persons suffering from the condition. So it is my hope really that the knowledge and insights and discussions that will be shared in this webinar will hopefully identify gaps, provide insights and opportunities and potential solutions in addressing cataract surgery in Trinidad and Tobago and across the Caribbean. We in PAHO are extremely happy to partner with the Trinidad Eye Hospital to be part of this webinar and discussion on the challenges and looking at how we can together work to address all of these different challenges that we have in cataract surgery in Trinidad and Tobago. And we confirm our continued support to strengthening health systems, as Dr. Edwards so eloquently said at the beginning. So I want to close by thanking you again for showing up, and I look forward to an interesting presentation by Professor Bernie Chang, and I thank him again, and a very stimulating discussion to follow. Back to you, Ms. Mohammed.
Thank you so much, Dr. Leela, for that welcome and those words of insight, and it's always a reminder when we hear the the details of the data across the region. Thank you so much for setting the context and welcoming us to this meeting. Next on the agenda, we have a short video, which we will now take a few minutes to view.
According to WHO, globally, at least 2.2 billion people have a near or distance vision impairment. In almost half of these cases, vision impairment could have been prevented or has yet to be addressed. Cataract is responsible for 51% of world blindness. In Trinidad and Tobago, according to the 2013-2014 NEST study, cataract is a leading cause of blindness and moderate and severe vision impairment amongst adults. Since the onset of the COVID-19 pandemic in March 2020, it is estimated that thousands of cataract surgeries were cancelled, delayed, or put on hold, both regionally and internationally. As a result, many persons are at risk of permanent vision loss due to delayed review or treatment. Some patients decided to share their story with us.
I can't see the walk normal, and things I have to walk with a stick because I see cloudy, the eyes cloudy.
Her right eye, she was not seeing properly at all.
He always had to take pain tablets because his eyes was just, and it was like blood red.
Hardly seeing blurry in the eyes.
I can't see nothing. I can't even see the plate of food I eating. I can't really see nothing, I just have to feel. You understand?
Very long time. So I decided, yeah, long before COVID. 2 years now.
A few months, well, that the eyes get worse. The eye, especially this one, he left.
He went once, but you know the length of times, the length of time that the appointments and things like that, it wasn't working out fast because his eye used to be painful. So he decided to go privately.
They keep putting, look, since the beginning of, I think, this year, I think it was February, they put the appointment for quite August of this month.
You reach into the hospital, right? You can't get no help in the hospital because that is going to take years.
Do back, repeat what she couldn't do in school, what she didn't get through her subjects. She wanted to do that because, as I say, with this just one eye, and she cannot see properly to read, with just one eye. So it's a key back, it's a big key back in her entire life as a young woman.
I have a prosthesis, and I can't even use it. So I will take a chance to use it because I have not seen nothing. To put it on. You understand? So if I could get back with one of the eye, because there's 2 eyes, right? If I could get back inside on one of the eye, I could still use the prosthesis to move around without asking somebody for help now. You understand?
Okay. It's very emotional perspective from the patients. What the clip has done is really ushered in the importance of the feature address. So at this time, I will invite and welcome and introduce our guest and feature speaker, Professor Bernie Chang. Professor Chang is a consultant ophthalmologist who specializes in oculoplastics, lacrimal, and orbital surgery. He has been a consultant for more than 17 years in Leeds Teaching Hospitals NHS Trust and is an honorary senior lecturer at the University of Leeds. He also works in the private sector as a partner in New Medica, North Lincolnshire, and Wool. Professor Chang is also a visiting professor in ophthalmology, having been awarded this chair from the University of Malaysia, Sarawak, in January 2011 for his overseas commitment to teaching and training. He became the 13th president of the Royal College of Ophthalmologists in May 2020 in the midst of the COVID-19 pandemic, and has worked with the college on ensuring continued care for patients whilst trying to protect their safety. Professor Chang has over 60 publications in peer-reviewed journals and co-authored a medical textbook and several book chapters. He is like an honorary Trinidadian, being married to one actually. During his 17-year consultancy in Leeds, he had the distinct challenge of training many Trinidadian ophthalmologists. He forged a strong relationship with Dr. Robin Simongal Das, and over the years was able to help a lot of patients in Trinidad get the surgery that they needed without having to travel abroad. In the early 2000s, he spent a lot of time in Trinidad, falling in love with the people and the island. I think there was something about hunting for gyros in Port of Spain there too, but I'll let Professor Chang say more about that. So without further ado, thank you for accepting this invitation, and it's a pleasure to have you join us. Professor Chang, the floor is yours.
Hi, hopefully you can hear me okay, and I'm going to start sharing my screen.
Yes, we can hear you.
Great. Can you see my slides now as well?
Yes, we can see them.
Yeah. Okay. So firstly, thank you very much indeed for this opportunity to give a short presentation about how in the UK we have started to address cataract surgery capacity demand challenges. And as Franca has mentioned, I am a consultant but who works in the NHS, the government service, as well as in private practice. So eye services in context. In the UK, ophthalmology is the biggest outpatient specialty. We see 8 million patients a year, but during the pandemic, services were suspended. And in fact, patients were less willing to come to hospitals because of the fear for catching COVID. So outpatient attendances fell by 31%. And this was actually higher for eyes than for other specialties. So it's not surprising, therefore, that the backlog of patients needing care has been growing. And amongst the clinical leads in our hospitals, we predict it's going to take probably up to 3 years to clear the backlog. So in terms of cataract surgery, it's the most common elective operation in the UK. And the demand is going to increase because of population changes. So at the moment, pre-COVID, about 500,000 cataract operations are done with an approximate cost of about $500 million to the NHS per year. During COVID, all routine operations stopped, and that obviously included cataract surgery for about 6 months. And there's continued limitations for NHS hospitals because initially we had to look after COVID patients, but even now, patients with cancer and life-threatening diseases get the priority over eye patients for cataracts, which are considered more routine. We still need to routinely test patients for COVID, so that makes it difficult to get some patients in, especially if you get on-day cancellations. We can't just bring another patient in to fill the list anymore. So just as a comparison, so in the UK, we do roughly 7.4 cataracts per 1,000. And that's less than the US, that does about 10 per 1,000, but obviously more than some of the other countries. But as Dr. Wheeler has mentioned, and in the video, cataract surgery is definitely the most cost-effective operation. The study in ophthalmology predicted that you get a 4,567% financial return on interest for each cataract operation that you do. So in terms of the capacity issues, what we did in the UK was we started to use green sites. So by green sites, we meant independent hospital sites away from the main hospital that had to look after COVID patients. And in a way, by default, the independent sector hospitals were part of these green sites. So we knew that we had to improve efficiency. We have to get through more cases per list. And you can find recommendations that were co-written by the college and also by this Getting It Right First Time program on the website. What's clearly important is that you have to develop high volume cataract surgery units to get the numbers through. And you can do additional lists as well during weekends, but those lists should be as high volume as possible. And because of the cost effectiveness of cataract surgery, you shouldn't really ration. So you shouldn't put a visual threshold on who gets cataract surgery. So one of the things that you can do if you want to get through high volume is to risk stratify the patients that you see. And from that point of view, a very simple tool, which is on the screen on your left, is useful. On the right is the workforce calculator that the college developed. And it's quite a useful tool because what it can do is tell you roughly how many operating lists you need per year, how many hours of staff you need from consultants or surgeons to the nursing team in order to get your lists done. So here's an example for a population of 1 million. So let's say you want to do 7 cases a list and you have to get through about 6,500 cataracts. So that means you need about 928 lists and 14,800 hours of nursing time and also about 2,000 hours of operating time by the surgeon. But if you increase it by just 1, so you're doing 8 cases per list, you then only need 812 cases, lists per year. And in terms of the consultant hours as well, you need less. So the more productive you are, the less you're going to need and the more you can do to get through your backlog. In the longer term, obviously, you have to increase and invest in your workforce. And that includes your consultants, includes non-consultant doctors, nurses, technicians. And that's because the rate limiting step is often not the surgeon, but the theatre staff. Now, you also have to think about retention of staff because over the COVID period, quite a lot of people were mentally burnt out and physically very tired. And a lot of consultants have considered retiring early. So you have to have a retention program as well, I think, for your medical staff. And if your eye units are very old and the layout of your hospital is such that your theatre is on one floor and your ward is on another, you're not going to get through the high volume. So you have to modernize your eye units as well. And obviously that will require adequate funding. So in terms of NHS hospitals doing high volume lists, the main challenges were that a lot of hospitals haven't had the investment to modernize their space. And there was competition for their theatres during COVID for other more life-threatening procedures, the poor layout I mentioned. And also have to remember that the workforce numbers is a limited pool. So whether the staff were working in the NHS hospital or in the private sector, they tend to be the same staff. And therefore, this created competition, which is not necessarily a good thing for delivery of health services. So what we have noticed in England in particular is that the provision of cataract surgery has changed. So pre-COVID, the independent sector provided maybe around 21% of all cataract operations. But since COVID, it is about 50 to 51%. And so lots of little independent sector providers have come up, and lots more day case hospitals have been built to perform cataract surgery. So what's the impact of that shift? Without a doubt, the waiting list has reduced. I don't think we have any long waiters of over a year for cataract surgery in the United Kingdom. And indeed, the independent sector was very important because of the backlog of patients needing surgery, which was about 600,000. But the greater reliance on the independent sector can cause concern for existing eye units, because the funding can be shifted away from the government hospitals or NHS hospitals into the independent sector hospitals. And that's an important consideration, because it's the NHS hospitals that deal with the other conditions, emergency care, out of hours, etc. And training of ophthalmologists and eye care staff was becoming more challenging as well, because the hospitals were not doing as much work as before. So in terms of addressing the training challenge, we developed guidance with our health education bodies, and we wrote guidance on how you can train even in high volume cataract surgery units. And again, that's all available freely on the website for people to access. The independent sector itself has embraced training in the NHS. And although it's been slow to take off, I think they themselves see the benefit of having trainees working in their hospitals. I think for one thing, it encourages consultants to then consider working in the independent sector once they get their qualifications. So from the college's point of view, on what our key priorities were, the college sets the standards so that patients get the highest quality care possible. And from our point of view, we knew that we had to increase access to training for our trainees, that we had to try to level the playing field between providers to ensure that patients get better access to their care. And there has to be a proper selection criteria for the independent sector as well, so that they can do the more complex cases and not just do the routine cases. So in terms of safeguarding quality, we do have a national ophthalmic database. So providers are expected to contribute their results for cataract surgery to this database. But I think it's very important that long-term sustainability of the eye care service provision is considered for whatever solutions you find to deal with the cataract backlog. So the next few slides is just about the importance of auditing your results. So since the National Cataract Database was introduced, we have had 4,500 fewer complications per year across the NHS, which probably saves the NHS about 2.5 million per year. So auditing your results can drive up quality. So this is just an example that the posterior capsular rupture rate has been decreasing each year on year since the National Cataract Audit was introduced. Numbers do matter as well. This is a graph showing complication rates in terms of PCR, depending on the volume that you get through per year. And you can see that there are a few consultants who do 6,000 to 8,000 cataract operations per year, and their complication rates is very, very low in terms of PCR. So the other interesting finding from the cataract audit is that posterior capsular opacification rates can differ depending on what type of intraocular lens that you use. And the risk factors that increased PCO were hydrophilic lenses, if a patient had a long eye, or previous vitrectomy or past iritis. So there may be an opportunity, therefore, if you choose the right lens, that you will lower PCO rates. And why is that important? Because then less patients will need yak capsulotomy. And that is a saving for the NHS. Plus, that saving can then be used to treat patients with other more life or sight-threatening conditions. But of course, is it a good or bad thing? Because in a sense, when you do a procedure, particularly if you work in the independent sector, that generates a tariff. So I think to summarize, if you're going to tackle the backlog and the need for your patients to have cataract surgery, I think it's vital that everyone and every provider, commissioner of health services works together for the long-term solution. And I think it's important that you also think beyond cataract surgery, because in a sense, it's patients with diabetic eye disease, macular degeneration, delayed glaucoma follow-ups that are more likely to go blind than if you delay your cataract surgery for a few months or so. So you have to incorporate training as well in the provision of cataract surgery, wherever you are, I believe. So whether it's the government hospital or the independent sector, the private sector, you should offer training as well, because unless you train your future surgeons, you're not going to have the workforce that you need. So there must be continued investment in the NHS government eye units to modernize their service as well. And the independent sector can definitely play an important role to improve access and capacity, but it should be done in a properly planned way so that you have a collaborative approach rather than a competitive approach. And finally, it's very important to audit your service and the results, because that will help drive standards and efficiency. So this is a UK experience, and I think each country probably has its own unique challenges and will have to find its own solutions. But there needs to be a willingness to invest in the work that needs to be done. And you have to make use of all resources that's available for your patient's benefit. And society will gain on top of that. So thank you very much for listening.
Thank you, Professor Chang. Thank you. Yes, that was a very insightful presentation. Lots of information shared. So we've reached the discussion portion of the evening. And I really want to, at this point, I want to invite Dr. Dorian Dwarka, who is a consultant ophthalmologist at CBRS and head of ophthalmology department at Tobago Regional Health Authority, to moderate this part of the program where the discussion is going to take place. So Dr. Dwarka can take the floor.
Good afternoon, everyone. We want to say thank you to Professor Chang for his very insightful talk. We also wanted to say thanks for all the participants, Dr. Edwards, Dr. Erica Wheeler, all public health officials, both from Trinidad and Tobago and from fellow Caribbean islands, CEOs and other RHA interest personnel, including medical chiefs of staff, and all participants in general. So what we're going to do today is we'll be opening the floor for anyone who has questions. So basically we would raise your hand and we could take your questions. But specifically, Professor Chang, we really appreciate your well laid out discussion. And just to start off the discussion, I would wanted to get your comments on how we could ensure that when we have the independent sectors helping us, how we could decrease the load in the clinics for sort of things like complications and so on that could take up clinic time, because they're not, the independent sector is unable to look after them.
Yes, so what we've done in the UK is we've worked with the NHS England and the independent sector to come up with a specification for what's expected of all providers for cataract surgery. And one of the things that's in there is that there should be a planned route for patients who have complications or who feel that there's something wrong out of hours. So the independent sector is either going to provide that out of hours service themselves, or they will approach a local eye unit and make sure that there is an agreement between them in order to get this, to get the patients managed properly. Because I think in the past, the NHS hospitals have kind of been landed with the complications, and that never creates a collaborative approach, basically.
Thank you very much, Dr. Chang. Any participants with their hands up looking for comments? Now, while we're looking at this, we want to invite Dr. Vish Ramdat, who is our president of the Ophthalmic Society of Trinidad and Tobago, to share his comments on the talk given by Dr. Chang.
Hi, Guru. I see Hazel has a hand up.
All right,
Maybe
so I missed that one. So let us we'll ask Dr. Hazel to chat first, and Dr. Ramdat will come back to you.
Yes, thank you very much. I'm from Dominica, and currently we in Dominica are just getting off the ground post-COVID. We are fortunate enough to have had a recently constructed eye center with many more examination rooms and our own operating theater in the eye center. And we are hoping to embark on doing more predominantly phaco surgery compared to extra cap and small incision cataract extraction. However, our concern is that we do not have any retinal services in Dominica. And most of our patients with cataract are older persons, frail, and have limited resources. In Dominica, all our patients 60 and older get their services free at the hospital. So therefore, during cataract surgery, if you have a dropped nucleus, then you have to be able to, that patient has to access a retina service. And Dr. Bola has been kind enough to, do some of our retina work, but this is going to involve a cost, transportation, accommodation, somebody to accompany them, and then the fee. So this has been actually, Dr. Lawrence is on board, and so she can bear me out on that. Our biggest anxiety, how are we going to cope with this complication? And especially we are starting off phaco now in Dominica, and most of our cataracts are hard cataracts, brown, black cataracts, counting fingers cataract. So, we have engaged Dr. Bola to try to develop an MOU with our hospital authorities to see how we can arrange prompt attention to this complication, and at the same time, how we provide payment for his services. But it is not a very comforting thought for us right now, embarking on cataract surgery. So I don't know if you have any suggestions or comments for us. Thank you.
So, if I may. Yeah, so I think,
yes, Prof.
So one of the things I suppose you can consider is how do you minimize getting complications? And the risk stratification, I think, is useful. In a sense, you don't want your least experienced surgeon in it doing the hardest cataract. You want your most experienced one doing it. So the chances of having a complication will be less. Now, I think it's really good that you are also looking beyond your own borders. So you are able to go out and reach places that are able to give you the backup that you require. Now, whether it's possible for you to find funding to set up a vitrectomy service within Dominica, I'm not sure, but that would be the ideal thing, so that you don't then have to fly patients out. But I think, again, with the risk stratification, you can predict which patients are bound to have trouble. The black cataracts with weak zonules, poorly dilating pupils. And perhaps it might be fairer for that patient to be, to go abroad to have their surgery rather than having it done locally if there's no backup. But as I say, it's very difficult when the resources are not there. But I think those are the things that you can consider.
Thank you very much, Professor Chang. So it's at this point a very opportune time to let us know a little bit about your selection criteria for your independent practitioners, because that probably tie in with this particular question.
So what we've done actually is made it very much more accessible. So in terms of the cataract itself is not a barrier to accessing the independent sector. What's a barrier is if you need a general anesthetic, if your BMI is, I think, more than 40, because it's very difficult to get trolleys that will fit them, but also it's tricky to do their surgery as well because they can't lie flat, so their risk of complications is higher. So apart from or dementia, for example. So apart from those things, actually, the independent sector now will take on virtually all cataract complexities. And we are, I suppose, in the UK, very lucky because all hospitals have a VR service. So complications can be managed. And the independent sector themselves have got VR surgeons working with them, and two have got their own vitrectomy service as well, and also looking after their endophthalmitis patients.
Okay, fantastic. So thanks a lot, Professor Chang. So turning over to Dr. Vish Ramdat now, who is going to share some of his thoughts.
Hi, good afternoon, everyone. Thank you, Dr. Chang, for that amazing talk. I think if Franca could provide that for everyone, it should be required reading. I've been following quite closely what's going on in the UK actually with wait times for cataract. I'm quite happy to hear that the independent sector has taken up a lot of the slack, and we have many parallels that occur in Trinidad with that respect. And I've always been an advocate of the excess cataracts being done in a public-private partnership. We have that on the books in Trinidad, but it's not utilized as much as it should be. The future in terms of amount of cataracts it's quite a lot. There's quite a lot of cataracts waiting. Even before the pandemic, our cataract surgical rate was required to be about 12,000 per year, which would require each one of the regions in North doing about 40 per week, which is about 8 cataracts per day. And in South, we would need to do about 25 per day, which I could tell you, working in South for almost 20 years, we have never actually done 25 cataracts per day in South, in the theater. So we are way underutilizing as you quite rightly said, the rate limiting step is not the surgeons. The rate limiting step is actually the support staff. And I mean, I am a very practical person. I can tell you just quite obviously, we have not only from the pandemic, but even before, there's a sort of apathy in terms of actually getting a list done. In terms of now, you must remember that there's a difference, and everyone should know there's a difference between a cataract surgery list and a high volume cataract surgery list. It requires a lot more precision, coordination. You need support from your logistics, procurement. If you're going to do 120 cataracts a week, you can't be ordering 100 cataract packs for the month. So in terms of, I've been to many meetings with many doctors, but I really would want to urge everyone here, all the heads of the different regions, if you could speak to your support staff, there needs to be a meeting, because they always tend to put eye surgery on the back burner because there's always life-threatening stuff happening in all the hospitals, because we have complete hospitals providing everything. You need to speak to your support staff in terms of procurement, logistics, biomed, even insisting on having service contracts, because quite frequently in the Caribbean, we have equipment breaking down. Now you have to remember, in the pandemic, our borders were closed. We couldn't even get a technician in, right? So we have to get technicians in to help service this equipment that we buy. So in terms of our unique situation, most of us live on islands. So everything has to be shipped in. Well, I know the UK is a nice island also, but we have to ship stuff in, and they have to store it, and it requires foreign currency. So it's a lot of things are going to happen in the future because, as you all well know, there's labor strikes, there's a chip shortage, there's the war in Ukraine. So a lot of things globally are going to affect us. So we need to actually utilize what we have as efficiently as possible. And when you start pushing high volume cataract surgery, they all look at the costs. And we must find a way to minimize the costs both publicly and privately, but still provide quality surgery. Now, we know in the UK there was a problem where all the easy cataracts, let's call it easy, but we really mean low-risk cataracts were headed privately. And the complex cataracts were headed to the training institutions where the doctors in training would be given more complex cataracts, which is not the way you're supposed to learn. So that we haven't actually reached that problem here in Trinidad because we got quite a nice range of cataracts. But in terms of takeaway from this meeting so far, I think we should all look at what Professor Chang said in terms of trying to look at the support staff for high volume cataract surgery. We also look at the importance of providing cataract surgery. And also every region should look at their cataract surgical rate and see if we are up to the level. And I just want to state finally that the risk stratification protocol that the college uses, I want to bring up in the next OSCT meeting that we should probably implement that in Trinidad because it's very valuable, as Professor Chang pointed out. Thank you.
Very much, Dr. Ramdat. We appreciate. Any comments, Professor Chang?
No. I think Vish, I think all he suggested is quite going to be quite useful, really. The question I had actually, you mentioned 12,000 cataracts per year. Is that right? Is that for Trinidad?
Well, using your figures, we have 1.3 million. So yeah, I think 12. We had come up with that figure about 8 or 9 years ago.
Yeah. That's low, because I think at 12,000 for a population of 1.2 million, you're only doing 1 per 1,000-ish. Whereas in the UK, we're doing 7.4 per 1,000. So theoretically, you should be doing a lot more. But maybe my maths is wrong. But regardless, I think that's very important. You have to kind of assess what your population demand is or need is for cataract surgery, and then plan your service to meet that demand, knowing that there's going to be probably a 25% growth per year, roughly, because the population will live longer, etc.
Yes, quite true. And a lot of our patients, we have a high percentage of diabetics. I think it's up to 20% of people in Trinidad now. So we have quite a lot of young people coming in with cataracts.
Thank you very much there. So Dr. Ramdat and Professor Chang. So at this point, we would ask Dr. Bowler. He had asked a particular question that was quite important too. And we'd ask him to just give us some thoughts on the private sector perspective on the cataract problem.
Right. Thanks, Dorian, for the question. Now, let me just get an opportunity just to answer a little bit of what Dr. Shillingford had brought up, that issue of retinal services with cataract surgery. And that would be an issue all over the world. You really have to commend Dominica for thinking about the risk involved with the surgical procedure and then how to manage that risk. A lot of us don't do that. All we do is look at, let's just try and get the surgery done, but we don't look at it. Or if something goes wrong, what would I do? So it's important if you're going to start a new service especially, because you're not familiar with the surgical procedures, day in, day out, to really think about what you're going to do if something like that happens, which could be very detrimental to the eye and then to the patient. So I want to comment on that forward thinking. Now, what I have noticed, because we've been to Antigua and we started to do cataract surgery there. By going there and doing the surgeries, we got to see what it's like to do surgeries in an island where there haven't been a lot of surgeries going on for an extended period of time. And what Dr. Schillingford is saying there is so true. We see that there is a lot of difficult cases, difficult cataract that need doing. And these people really cannot travel to do the surgeries because the mobility is a big issue for them at that stage. So I understand her plight. Now, what I have noticed there is what Dr. Chang has brought up, that pre-op assessment that the Royal College have recently published and developed, we have been able to use, and Dr. Chang, I am so grateful for that publication, because we have instituted that in Antigua. And what that has done, it has allowed us to stratify the cases. So then we know the level of difficulty before we turn up to Antigua. We could already start preparing for the cases with that pre-op assessment. So that when we get there, we already know what are the high-risk ones, what are the low-risk ones, and then how we're going to deal with them, or which ones we shouldn't really do without vitreoretinal support for that case. So that's something that Hazel and myself could work on to really get an idea of the risk of the case and therefore what is the best way to manage it. So that's something I think would be really helpful. The other thing that we've been doing in Antigua is doing a lot of training for the teams there to develop them to not only be able to do the pre-op assessment and everything, how the college designed it, and therefore help us to make good decisions on the cases, but also to start developing their team to be able to do the surgeries, and therefore we share the burden of care. So that would be something I and Hazel could work on in trying to develop now in Dominica, a future where we do we develop cataract surgery locally there. The other thing that we've been looking at is taking equipment to Antigua, because now cataract surgery, as you know, the earthly machines and everything is portable. So I could take a biome, which is a viewing system to do retinal surgery. I could walk with a vitrectomy machine in a suitcase, and I could turn up into your unit. And now I don't only have cataract surgical services available, but also retinal surgical services in case we drop a lens or something. So I think the future is not that we wouldn't be able to cover retinal services in other parts of the Caribbean, but we will find innovative and unique ways to do so to make everything safe, which is what I think people want. The question to me really is what as Dorian was asking there, is private providers in eye care. What really is my perspective on this problem here? And it's a little bit different in Trinidad than in some of the other countries. And I'll talk a little bit about Trinidad first. I think one of the things, and Dr. Chang brought it up, is data. You know, if you don't know what is the state of the problem, then when we introduce a solution, we don't know if that had any impact. And I think one of the first things, you know, I would want to see us do is to get data on where we are, which is, I was suggesting the cataract surgical rate would be one of those data points or data sets that we'll have to look at. Dr. Chang was talking about PCR rates, and I think endophthalmitis rates. All these things, we really need to start collecting data on where we are and what we're doing, and where these numbers are. And then when we start to discuss and meet and discuss solutions, when we introduce a solution, how effective those solutions would be, it would be very important, because then we'll see when we re-audit or look at the data again, then we'll know. So data is important, and that then will lead to data-driven decisions to help us make good decisions going forward. The second thing, and Dr. Chang brought it up too, is what I call partnership. You know, we need to partner. We need, as the independent sector, which is the private sector in England, partnered with the public sector to get a solution for the cataract backlog. I think in Trinidad, where we have such a good and strong private healthcare sector, we need to see a partnership between the two to help this problem. And really, we need to look at it because people suffering in this country. And we have to really not only make this happen for us, but really for the people who we've seen in those videos, blind from cataract, and they really need us as the healthcare leaders to do this, to start the conversation, the real conversation, which will bring forth real solutions for these people. Thanks, Darren.
Thank you very much, Ronnie, for this sort of situation. So, Professor Chang, so we've had throughout our history in Trinidad and Tobago, a more recent history, we've had several little projects that we partnered with private suppliers, and what was an interesting thing about it was we had to make a decision on how to spend cash. Remember, funding is an important thing. We have funding for consumables, funding for capital development, for all these other things that are important. And the issue always came up how we were able to sustain our departments and make sure it continues to have adequate funding when we're competing for this funding to give to develop let's say, an independent sector program. So it becomes a tricky thing for an administrator. How does one make the case? Now, when one deals with private suppliers, in a lot of ways, they put across a very rosy picture. But one can only make a decision whether it's if we were to have the data, as Dr. Bola was talking about. But we find within our institutes, our public sector hospitals, we are unable to cost cataract surgery well, because costing is a very difficult thing, because we actually cost lower than what it actually costs to do a surgery. I would wonder if you could share your thoughts on how we could go about solving that issue to allow us to have a reasonable comparison between public sector spending on a cataract and private sector spending on a cataract.
Yeah, so tariffs in the UK, how they're calculated, I don't think it's perfect. So essentially what the NHS does is it looks at different types of hospital, large teaching hospital to a smaller district general hospital. And they say, well, on your cataract list, what is the volume that you get through, right? Let's say it's 8 cataracts. How many surgeons do you have? How many nursing staff do you have? That includes the day case, you know, the nursing staff to look after the patient, bring the patient across, etc. And so then you then put a cost to the time, you know, whether it's 20 minutes per cataract or half an hour per cataract. So that's how they cost it, and they average it out and then divide it so that there's a cost per cataract. So it's roughly around £740 for a routine cataract with the cost. Now, actually, if you're efficient, like the high volume units are, with that amount, you can actually make profit, which is why, you know, when you have too much of the routine things going to the independent sector, you can potentially destabilize the NHS unit. What I would say, though, is that there's so much backlog, and it's not just cataracts. As I mentioned before, you also have to think beyond the cataract. You know, your diabetic patients who need their vitrectomy, their laser, your AMD, macular degeneration patients who need their injections, they're also waiting. So theoretically, if the hospital is not doing as many cataracts, they ought to be able to do more of the other stuff, which also generates an income for the hospital. So you can then kind of make the financial sustainability a little bit better from that point of view. But that's how tariffs are calculated in the UK. You look at the list, you look at the resource, including, you know, the electricity bill for 20 minutes in that particular hospital, and then you put a cost to it. And going back to Hazel and Ronnie's comment, my challenge to the Caribbean would be, you really should have as low a percentage of those very complex cataracts as possible. You know, if your percentage of hard cataracts is 20, 30, 40%, you're doing them way too late. You should be reaching them before they become so complex. So clearly, you need to think about increasing your capacity and getting patients in much more quickly than you are doing now.
Very well said, Professor Chang. So we appreciate that comment. We'd like to, Dr. Faizuddin, one of our participants, would probably want to share a comment with us at this point in time.
Good evening, I'm Dr. Delicia Faizuddin. I am an aspiring ophthalmologist. Firstly, I would like to say I'm so grateful to have heard this presentation and to be part of this forum, as I'm very interested in research in this area. And as Dr. Bowler mentioned, data collection is so important. Fortunately, I've been part of the preliminary discussions to study the CSR in Trinidad and Tobago with the end goal of publication. So the CSR is a number of cataracts done per million people in a population, and it is a good indicator of the rate of blindness prevention due to cataracts. So I look forward to collaborating with both public and private providers of cataract surgery to do this research. And this meeting has given me really extra motivation to pursue this objective. Thank you.
Thank you very much, Dr. Faizuddin, for that. And Dr. Faizuddin, were you able to collect any data and analyze any of the data with respect to our cataract surgical rates? Do you want to comment on?
We haven't officially started the program as yet, the research study, but we are set to start in August to collect data.
Thank you very much. So this will be a much welcomed piece of data that is important for us. And while we wait for anybody else on the floor, I will ask, I'll ask our President of the Ophthalmic Society of the West Indies, Dr. Allen, if he has any words that you'd want to say.
Thanks, Dorica. You know, I've listened to all the discussions, and they're all pertinent. The English, the UK problems. The West Indies is a lot different. We talk a lot of Trinidad. We really haven't heard anything from Jamaica or Barbados. We heard from Hazel. The solutions that Hazel looking at is particularly for Dominica. And then Ronnie talks about Antigua. One of the problems would arise is, do we have enough vitreoretinal surgeons to go to every island? I think we need government-to-government collaboration to help these things work, so that one of the big problems is patients' affordability. They can't come to Trinidad to have vitreoretinal surgery. Perhaps there could be some form of government-to-government relationship that would help patients with that cost, instead of looking at private sector. Agreed, private sector has a lot of the resources in Trinidad pertaining to vitreoretinal surgery. For the rest of the islands, like in Dominica, St. Kitts, where there are not many surgeons that we know about. As we, only knows about the local surgeons. We don't know about the foreign surgeons who go there and do their work. They don't belong to OSWI, so we don't know. I think there needs to be a more government-to-government collaboration. Maybe I'm being naive in the Caribbean, so we can take in all, because we have all levels. We have islands with many ophthalmologists, and then we have islands with just one. So it's a difficult problem, and I think we need to look at a more generalized Caribbean solution to this. That's well. Oh, and let me correct the monitors. I am the past president of OSWI. The present president is Dr. Sharma, and Dr. Ronnie is our vice president. So that's my comments. Thank you, and thanks a lot, Dr. Chan, Professor Chan. That's a very, very good talk, and wonderful. Thank you.
Thank you very much, Dr. Allen. Sorry about that. My apologies on the position, and we apologize to Dr. Sharma for me. So I'll do so when I see him next. Professor Chang, any comments?
Just to support what Dr. Allen has said, I think, yes, you do need collaboration, and you probably need your relevant health ministries or Department of Health governments to get together. But I think the data is really important, because you have to know what the demand is to plan the capacity properly. And with the public sector, private sector partnerships as well, obviously in the UK, in a sense, perhaps we learned the hard way, is that, yes, there's always a tendency for you to want to do the easier cases. But if you have a proper collaboration, that should not be the case. You know, the complexity that is done in the private sector and the public sector should be very similar, unless they're really things that can only be done in a hospital, for example, if you don't have general anesthetic facilities, etc. But I'm hoping that with this meeting, you know, it will encourage people to invest in getting that data, and then also invest in the resources that's needed to improve everybody's vision.
Thank you very much, Dr. Chang. So just before we close off our session, can we ask Dr. Paul Edwards, is he still with us, if he can give a comment with respect to Dr. Allen's comment?
I'm sorry, this is Dr. Wheeler. Dr. Edwards just had to leave. He's traveling to Brasilia tomorrow morning, very, very early. So okay, he did let Franca know that he had to be excused.
Excellent. So in that case, we're hoping a speedy, safe trip. Dr. Erica Wheeler, are you willing to give a few comments on Dr. Allen's concern about the public sector involvement and the ministerial level involvement and the regional body involvement?
Well, from the perspective of PAHO, the way we work is that we try to engage the Ministry of Health as far as possible in the work of PAHO. Of course, we do cover eye health as well. The issue is, and I've had these discussions with Franca when we've been together, that it has to be the desire of the Ministry of Health and of course the CEOs as well at the RHAs to bring about change. It is what we do is we work to gather evidence, we share best practice and policy, we convene people, we give the best possible advice, but then it is up to the government. We can't force the government, but we can, I think, one of the things that has already been discussed, which I was going to say in my closing remarks, you know, that Dr. Bola raised it about conduct a study to determine the cataract surgical rate in the public and private sector. You know, one of the things we do is we work with government or with institutions like the Trinidad Eye Hospital to gather evidence. Okay, so once that evidence is gathered, then that is something that can be taken to the government and partners convened around where do we go from here? What are the gaps that we need to fill? You know, the discussions we've been having here, and I've been listening to someone, the doctor from Southwest, talk about the number of cataract surgeries that should be carried out, and it's nowhere near that. So obviously there are gaps. Then there is the whole issue of what do we do at the sub-regional level, as we would call it. But it all starts with evidence and information, because without that, it's just talk. So partnerships are very important. I think coming together to show the need for it and the evidence, and then taking that to, well, in the case of Trinidad and Tobago, and I'm sure with the other islands as well, the chief medical officer and the officers concerned at the regional health authorities or the equivalent in the other islands to come up with what could be the possible solutions at a sub-regional level or at a Caribbean regional level. We do have a sub-regional office, and we do have a regional office in Washington. So there are things that can be done at different levels, but it requires partnership and networking, evidence, and of course, the public-private partnerships, which the Eye Hospital has already been engaging in. So this is the way we work. We start with the evidence, and we try to end with policy that is articulated in change through implementation on the ground. But we have to see where the gaps and the challenges are and actually document them first. Your mic is off. I can see your lips moving.
Yes, thank you very much, Dr. Wheeler. Yes, Dr. Prasad had a question for us. That's Dr. Shivana Prasad. We'd appreciate now.
Hi, good evening, everyone. I'm not sure if I might have missed it with respect to the comment that Dr. Faizuddin was speaking about the cataract surgical rate. Was this supposed to be is it actually a private initiative or a public, the research that she's going to embark on? That's just what I was wondering.
Dr. Faizuddin, can you comment on that?
Okay, so it's a public-private partnership. So we're working with private hospitals as well as the public hospitals to collect data.
Thank you very much for that. And Dr. Amdat, a comment?
Yes, I just wanted to just piggyback on what Dr. Allen had said about vitrectomy services. And just look at the data, the PC rupture rate had reduced in the UK to 0.91, which if you take it to be 1 per 100 cases, if you're going to do 12 to 15,000 cataracts, you're going to have about 150 PC rupture, which even if half are dropped nucleus, you would need to have vitrectomy support, even in the best of hands. So yes, we could talk about cataract surgical rate, but even in our hospital in San Fernando Gerald, we had a Cuban there for the past 3 or 4 years. And so we need to have VR support if we are to embark on high volume cataract surgery. So I just wanted to just make that comment also.
Thank you very much, Dr. Amdat, for that very topical thing. As we will universally agree, any high volume surgery with respect to cataract will generate a substantial amount of cases just by the statistical and the significant statistics of the situation. So budgeting for these things should include that. And this is an important part of our planning arrangements. And as Professor Chang was pointing out, this was also crucial in the experience they had in the UK. The floor is still open for any other comments. Professor Chang, anything you wanted to add to that?
No, I think you do need the backup in case of complications. So I think that's only fair to the patients. But again, when it comes to the numbers, the higher you do, the 0.91%, don't forget, is the average. but the higher the volume, the lower your complication rates actually. So I suppose one of the things that is being thought about is, is cataract surgery a subspecialty of its own, so that it's the high volume surgeons or people who can do high volume who are the ones who are going to be doing most of the cataract surgery in the future. I suppose that's something, again, for every place to consider.
Thank you very much, Professor Chang. So just before it'll be quite interesting for any one of our administrative members of the regional health authorities who have to deal with the policy making and to help us make decisions in terms of funding and so on, if they had any inputs with respect to this particular issue and how, with respect to how one goes about and as part of administration and deciding whether we could engage with a private partner to provide cataract here. And in the meantime, I'll ask just Dr. Bolatif to let us know if he has any additional thoughts.
Yeah, in regions like these in the Caribbean where you have 100 people who are not seen so well from cataract surgery, and we worried about 1 drop nucleus or 2 drop nuclei, I think you really have to take it in context. This surgery is life-changing for a lot of the patients that you're going to operate on. Yes, you might have a problem with a couple of them. We know that drop nuclei do not lead to, in general, do not lead to total blindness within a week, within 2 weeks. So they could be sent to have surgery. In Trinidad, it's much easier than in the other islands because you have retinal surgeons here. The cost is the issue, and what we could work out, it's easy to work that out here, is to have a plan in place because you're going to have, if you're going to do 1,000 surgeries, you're going to need 3 vitrectomies done on these 1,000 cases per year. So it's easy to work the maths out there and get something worked out. So I don't think it's a big issue in this country to do high volume surgeries and move with it. In the other islands, you have to have a little bit of a plan in place if you're going to do more and more cataract surgery. Even if you're doing low volume surgery, there is a risk there. So I think the way to look at it going forward is to use the model designed by the Royal College, stratify the cases, start with the easy ones first when you're starting off. So the risk is very low of getting into trouble. And then as time goes on, you up the ante. You take on more difficult cases when you get more and more experience. And also you have partnerships, with guys like Rishi Sharma and other retinal surgeons, so that they come in and they provide support with you while you develop your unit. I know Sherwin Benskin goes to Guyana and he goes there and is trying to develop the retinal services there, the unit there, so that that's going on. And then I go to Antigua and we're going to be developing there. And then I'll go to Hazel there in Dominica and we start developing. So things will develop. I don't think we need to be thinking to not start doing the cataract surgeries because there is that risk. I think we have these links and systems in places to deal with these risks when they do happen. Luckily, it doesn't need to be done within 24 hours. You could manage the pressure and the inflammation and then get the patient sorted out later on.
Okay, thank you very much. So I will take the opportunity again to thank Professor Chang for taking his time and giving a most interesting talk, and to all the participants, we appreciate your input, and we turn you over across to Franca now.
Thank you so much, Dr. Dwarka. That was certainly a very exciting discussion. Very, very interesting. So many people sharing their experience. I really think it was a wonderful discussion, and thank you for moderating it so well. So we're getting close to the end of the agenda. I know, Dr. Wheeler, you came in, but we do have you marked down to share some thoughts on the way forward. I don't know if you wanted to add anything else before we do the thank yous.
Well, thank you, Franca. I think from our perspective, as I said, I think I have both between Dr. Bola and myself and a couple of other doctors. I mean, there's a clear recognition for this public public-private partnership going forward. There is a tremendous amount of interest. There's still 47 people on the call, which I think this is only the first of what I think should be others. There's clearly a need for network, which has started, the networking has started. And always I believe that as you all are running with it, there's no need to wait on government, but certainly in order to scale it up in the public sector, there is a need for dialogue and for action to be taken. And as I mentioned, the role of WHO and PAHO in these circumstances is to bring different groups who don't normally speak to each other into the same space around evidence and kind of put them in a position where it's obvious what the problem is, and then ask, well, how do we move forward from there? Sometimes we can procure seed funding to have start certain initiatives, but I think certainly the networking across the Caribbean is important. I think we should think of next steps coming out of this. I know notes will be taken and so on, but I mean concrete next steps, because it would be a shame to have a webinar like this with such a rich discussion, exchanging ideas and so on, and then as a group that has come together, we don't take it to the next step. But the issue of evidence continues to be critical. Doing the research, having a study, and I heard from a university what is happening there. But this is what we need to help, I would say, as part of the next steps, confronting governments, or confronting is not the right word, but presenting evidence to government about what's needed. And many of the people on this call know what happens in their own RHA. So getting that kind of information together and continuing to network will be critical. We will do our part as we are called upon, but just be assured that we are happy to be partners in this venture. So back over to you then, Franca.
Thank you, Dr. Wheeler. Thank you. It is very, very reassuring to know that after such an insightful discussion and so very engaging, these thoughts, we have to keep the momentum going and really make things happen so that we can keep the conversation going and find the solutions together. So thank you. And, as we come to a close, I have to say special thank you again to Professor Chang for your presentation, for your openness, for your sharing. We really appreciate all that you have shared on this call, and I know that the questions will continue to come. I mean, we will share your email with your consent, and also people having to read these slides and get all the information, sparking more ideas for possible solutions. I want to thank all the participants from every country represented in the region, participants from Guyana, St. Lucia, Barbados, Dominica, Jamaica, Antigua, and of course, Trinidad and Tobago. Your contributions to this afternoon's talk have really made for a rich discussion, and we are very grateful that you had decided this was a priority and you made the time to be here with us this evening. To the PAHO team, heartfelt thank you for partnering on this webinar, bringing this issue to the fore, and to the CBRS TH team who worked behind the scenes to make this webinar possible. I think Dr. Edwards had said, and Dr. Wheeler as well, that a report will be prepared based on the discussions had here this evening, and we would be circulating this report so that you can read more closely the details that were discussed and shared. Please also take a moment to complete the feedback form when you log off the session. What you will notice is that a pop-up would come in your browser as soon as you leave the meeting. Future questions, feel free to forward them to us. You would see contact information on that feedback form. And we thank you again for your time, and do have a wonderful evening. Okay.
Thank you. Thanks very much. Bye-bye.
Thank you very much, Franca. Thank you.
Bye-bye.
Bye-bye.
Bye.
Bye-bye. Bye-bye, Dr. Leland.
Bye-bye.
Bye-bye, Dr. Chang.
Bye. Yeah.
Nice to see you guys.
Thank you.
Bye, everyone. It was a wonderful session. Thank you.
Bye.
Bye-bye.
Please note, Dominica had a very good representation here. We had 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay.
Wow. So we're definitely going to be coming to Dominica.
Dominica had 11 participants here. Okay. So both from the primary sector and from the hospital, theater staff, clinic staff. Okay.
Wow.
I have to commend them for that. Thank you.
All right.